What just happened? Okay, and then the third was just to gain knowledge of some of the processes to consider, because if we're going to improve our community environments, right, we can't do that alone as healthcare professionals. If we wanted to improve our healthcare, like, for example, environments of hospitals and healthcare settings, we still need to work with our facilities folks in hospitals. If we wanted to improve neighborhood environments, we often have to work with architects, urban planners, transportation officials, parks department officials, school construction officials. So the processes for intersectoral collaboration and the partnerships are actually really important pieces. So environmental conditions, I'm going to start with some history. And you know, from the two folks who put up their hands, they were saying, hey, yeah, when you guys actually do work with public health folks, it's often in the area of infectious diseases. Well, you know, one of the key ways in which we actually improved those epidemics in the past was actually looking at the environments in our communities, right? So environmental conditions in our communities are often key determinants of what are going to be prevalent diseases in those communities. So I'm just going to take an example from New York City. If you look at the history of New York City in the 1800s, early 1900s, there was actually severe overcrowding in lower Manhattan. Densities actually about double what they are today in current Manhattan, with inadequate systems for water, sewer, garbage, leading to polluted water supplies, pervasive filth. So if you read some of the history books, you'll see that the drinking water pond actually was downtown, and you know, when it rained, like dead animals and garbage would flow into it. Before the creation of the Department of Sanitation, one of the reasons that you see the second-story entrances of brownstones is because prior to the Department of Sanitation, no one cleaned the city streets, and so things that fell on the ground just stayed there and rotted, right? And so if you could help it, you didn't want to be at the same level as that. You wanted to be a little bit elevated from that. So the major epidemics of the day were related to crowding and lack of ventilation in the buildings, waterborne diseases like cholera, vector-borne diseases, because you know the streets often were dark and dank. So prior to the days of zoning, the buildings were clustered very close together. Light and air could almost never penetrate into the streets, so you always had standing puddles of water that bred mosquitoes. So yellow fever was also a common epidemic in those days. So changing community design was one of the key ways that we actually achieved these successes. After multiple cholera epidemics, the city said, I think we're going to need a new water system, created the new water system, which was the Croton Aqueduct in upstate New York, that remains today the water system for New York City. Central Park, when it was created, was actually hailed as ventilation for the working man's lungs, because if you didn't have a large courtyard in your building, often the tenements didn't even have windows, and so these public spaces where people could go get fresh air and sunshine came from these public amenities. Sanitation department was created in 1881 and started cleaning the city streets of the horse manure, dead animals, and all the garbage that had been there for years. Tenement House Act actually banned the construction of dark, airless tenement buildings, requiring windows. Should I do something so that it doesn't like move out again? And then with windows, you now had ventilation and sunlight enter interior spaces. The subway was in large part created to address that overcrowding in lower Manhattan so that people could live in upper Manhattan and the Bronx and yet travel quickly down to the place of commerce and jobs, which was still lower Manhattan. And zoning started to say that buildings had to be positioned a little bit off from each other and step back from the street. And then all of a sudden, sunlight entered, dried off those puddles, and those mosquitoes that were ever prevalent previously went away. Now, successes in infectious disease mortality, you'll see this in, I've seen some recent Canadian slides on this as well, but you know, 1880, about 60% of mortality due to infectious diseases. By 1940, prior to the widespread use of antibiotics, because penicillin, not discovered until 1939, not in widespread use in 1940, but you can see that the major gains occurred because of these environmental changes. Not to say that once people are sick, we're not treating them, but nevertheless, you know, two things. One is, prior to them being sick, preventing it is key. The other is, even after they're ill, right, often the things that we're asking our patients to do, like eat more healthily, be more active, still require them to have supportive environments to be able to successfully achieve those outcomes. And that's what the evidence is showing us. So, you know, the health crises of the 19th and 20th centuries, from, you know, the work that we did in that time, improved, and now we've got, of course, a different set of health crises, chronic diseases, aging populations exacerbating that as well, mental health issues becoming larger burdens of morbidity and healthcare utilization, and then, of course, environmental change, climate change, and pollution, air pollution, that also contributes to some of our chronic conditions. I don't need to show this to a group of I think, Department of Medicine folks, but nevertheless, the burdens of chronic disease now are globally huge, not just in the developed world, but also in the developing world. Number one cause of death now. You could see it parallels, right, the 60% of deaths that were previously from infectious diseases in the 18th and in the 19th and early 19th and 20th centuries. Now the burdens are falling on chronic diseases. Major risk factors that are preventable. I highlight the ones in red because, you know, of course, inactivity, unhealthy diets related to hypertension, overweight, obesity, hypercholesterolemia, and hyperlipidemia. But, you know, physical inactivity, unhealthy diets, we've done a lot of policy and environmental work around tobacco and alcohol, but insufficiently, I think, around inactivity and unhealthy diets. So we're going to focus on that today. So a recent ICES study in Ontario basically estimated that approximately, so this is the Institute for Clinical Evaluative Sciences, estimated that about a third of hospital days are due in, at least in part, to physical inactivity diets, smoking and alcohol, translating to nearly a quarter of total healthcare costs. Of course, we know total healthcare costs are increasing in every province in Canada, and they're also eating up an ever larger portion of the total provincial budgets that contribute to other things that are needed, right, like education, municipal infrastructure. So, you know, some of these other sectors really do need to work with us, because if they want their budgets maintained, if healthcare costs are not contained, they're going to not have the budget that they need either. So participation, I think, you know, many of us grew up with all those ads about participation and being active. You know, they've, in terms of their data, suggests that about 5% of our children are getting the 60 minutes a day of physical activity that they need, and about 15% of adults. In other words, the vast, vast majority of adults and children do not get enough physical activity for health. And of course, you know, for weight control and weight management, the requirements are even higher than those minimum for disease prevention. So 21st century needs, you know, I think in the past, and still today, as a remnant of that past of infectious diseases and epidemics of infectious disease in the past, I think, you know, clinicians do work with public health professionals in addressing those infectious diseases. But I would like to talk today about what are potential collaborations going forward on chronic diseases and these 21st century needs. So, you know, I think three things related to that. One is we can apply lessons that we've learned from previous collaboration and successes in infectious diseases to help us structure how we might approach chronic disease issues. Within that structure, you know, we do need an evidence base for key risk and protective factors and pathways of propagation so that we can intervene on them in the community setting. And I'm going to present to you the evidence that's growing, and in some cases actually sufficient and strong through systematic reviews for community environmental interventions. And then I'm going to present some of the work that we did in New York as one jurisdiction that we can think about and, you know, adapting potentially lessons from. So if we're going to, so some of the key lessons are identifying key preventable risk and protective factors, and then the pathways of propagation on which to intervene. Intervene using a standard set of pillar activities. So if you go to any, you know, city around the world, usually the work being done around infectious diseases is very standardized. They're undertaking surveillance so that you're monitoring disease rates of reportable diseases. You are identifying outbreaks using that method. When there's an outbreak, there's, often for reportable diseases, if you guys see that, you're calling public health and saying, we've got a reportable disease here. Public health then is helping to address things like trace contacts, prophylax the contacts as appropriate, warn the contacts about signs and symptoms to be watching out for so that we can try to actually prevent further spread and even prevent it at the individual level in the contacts of cases. I think I have a set of things, so I won't go through it here. And then using a settings-based approach for monitoring prevention and control activities. So here are some examples, right? As I said, identifying key risk factors like infectious agents, the safety hazards, and then putting in place primary and secondary prevention measures like immunization, safety in buildings, safety of, for example, daycare settings as it relates to both injury safety and also, infectious disease propagation. Looking at all sorts of pathways, right? Air, droplet, water, waste, food, soil, vectors, bodily fluids, buildings, communities. Taking this very comprehensive approach and then intervene using surveillance and environmental monitoring. So, not only do we look for reportable diseases and do surveillance on them, but we do environmental inspections of food premises, of daycare premises, healthcare delivery premises to ensure that practices are preventing propagation of these diseases. Immunization programs, TB programs, STI programs are part of the sort of systems-based programming and interventions that are put in place. Policy development and enforcement, including environmental regulations that extend beyond healthcare. So water and sewage treatment plants, agricultural and food production and safety issues in that, building safety legislation and regulations, workplace safety in specific industries. Outreach and partnerships are needed beyond healthcare, of course, if you're going to work on these issues. And then, also the community engagement piece. Right? So I was actually really thrilled when the publisher came to me and said, hey, we want a book for the general public about these issues. And I'm like, you think people would be interested? And they said, oh, yeah, we think the people would potentially be interested in hearing about, what their communities are or aren't doing that are impacting their health. And so this whole piece about the public also being aware that, community environments impact them. For example, when environmental tobacco smoke became an issue, people became very concerned that, what was happening in the environments around them was impacting their health, their children's health, beyond which they had no control. And so this lack of control over some of these parameters could actually really mobilize the public to become activated, for their voices to be heard. And so, there's an expectation, right, that your drinking water is safe. When you go out to a restaurant, you're not going to eat and get sick from that food, right? So the public becomes extremely outraged. The public becomes extremely outraged when you have, even one case of a preventable water-related disease or a foodborne illness. And so I think we need to get to a stage where the public is also outraged that they can't get healthy food in their community, that they're overexposed in their neighborhoods to unhealthy foods and beverages, that they can't walk anywhere or bicycle safely, take their children to school by those modes, right? Because that is, of course, impacting their risks and risk factors for chronic diseases and mental health issues, too. Using a settings-based approach, so thinking across multiple settings, daycares, schools, adult settings that include workplaces, vulnerable populations like affordable housing, shelters, seniors housing, long-term care, healthcare settings, making diseases reportable, community settings such as, for example, public health often reviews when new developments are being put in place. They're reviewing those developments for their sewer and water infrastructure. They're reviewing for, if it's a brownfield site that has had lead or mercury or other sorts of contamination, to mitigate those. But they're not necessarily, in many cases, saying, why is there so much, why is this community, why is this new development going to be filled with so much fast food and convenience stores and zero grocery stores or farmers markets? Or why does this development why does it have no sidewalks or, any opportunities for walking for the residents? The schools that are being built, they're way too far away for children to walk from this community, and you have to cross this major highway, too dangerous. And so there are opportunities, I think, for us to start to think about how do we start to do more of that work systematically across communities and cities. And then food retail production and settings, right? So we do restaurant inspections, but we don't care at all about, in many cases, about what's being served in terms of chronic disease risks. Or people even have the information like menu labeling and calorie information, sodium warnings as they're making their choices in these retail settings. So what's needed is applying these lessons to these 21st century crises, right? Obesity, inactivity, sedentariness, unhealthy diets, social determinants like working conditions, social isolation, lack of social supports that can contribute to these risk factors, but also directly to diseases like cardiovascular disease and mental health issues. And then addressing these pathways of propagation for risk and protective factors, including our community neighborhoods, the streets, the buildings, physical and social environments of different settings like work sites, schools, and daycares. So here's some of the evidence that's been reviewed by the U.S. Task Force on Community Preventive Services, and that's a task force that's put together by the U.S. Department of Health and Human Services, run out of the CDC, and they undertake systematic reviews. I'm just going to do this just to make sure. To do systematic reviews of the literature to look at not only what's good to do in our healthcare settings, but also in our community settings. And so community design turns out to have sufficient evidence. I don't know what that is. Yeah, I will. Oh, I see. Okay. Oh, yeah. I just didn't want it to be like, that's a beeping to warn you that the slides are going to go off. Okay. So community design, right? There are many neighborhoods just sprawling single-family homes. And that usually produces a situation where you have insufficient people density to have any services be able to survive around them, right? So if you want people services around you where you can walk to, or it's not so far that you can't walk or bicycle to, then often you have to have enough people. And population density is achieved usually by having a mix of housing types, right? So not just the single-family homes, but also some condos, some duplexes, so a variety of types of homes, including higher density types like multifamily, so that you can have enough people. Once you have enough people, you can then probably locate services close enough for them to walk to, bicycle to, but then of course you have to connect the people to those services with safe and pleasant walking paths and cycling paths, and if you have to go a little bit further, transit as well, which usually starts or ends with a walk if you design it well. And then, zoning, how we design our building codes. So building codes shape, for example, what the buildings look like on the outside, particularly the first two levels. That can impact, the sense of pedestrian safety and pleasantness, government policies and builders' practices. And when these are done, the studies across studies that have been reviewed, there is a 161% median improvement in physical activity levels. There's also secondary benefits for isolation, crime, and stress. Of course, when people are out on the streets, there's more eyes on the streets in terms of safety. They're more likely to interact with their neighbors. Street design then also contributes. We talked about having those paths for cycling, walking, but the lighting of those paths are really important for safety. Infrastructure for safety of street crossings, traffic calming like street bumps and traffic circles, enhancing landscaping so that it's pleasant to do so, And those can be shaped again by building codes, roadway design standards, environmental changes that developers use and governments use in their public realm work. Associated outcomes, 35% median improvement in physical activity, again, impact secondarily sense of community and decreased isolation, reductions in crime and stress. Building design, right, including our healthcare buildings, right? That's a picture from Memorial Sloan Kettering. There's now actually technologies where you can encase things like stairwells in glass. In the past, you couldn't because glass would explode, right, when exposed to heat. But there's now fire-rated glass that can be utilized on stairwell doors, et cetera. And studies show that if you walk into a building and you can actually see the stairs, the elevator's right there, but just tucked behind a turn, that will increase stair use amongst building users. Natural lighting in stairwells, which is actually also really good for emergencies, particularly in high-rises, right? So some of the really old affordable housing buildings in New York, during like some of the storms and hurricanes that we've had in recent years, people were literally stuck in their towers because the elevators went out when the electricity went out, and people were too afraid in some of those neighborhoods to use the completely darkened stairwells, right? Afraid for both injury-related safety, but also crime-related issues. Designing for aesthetic interventions. In very high-rise buildings, people may not be able to or want to walk 30 flights, but you know, there are buildings now that actually program. There's one elevator for people with disabilities and carrying heavy loads who might need to stop at every floor. But the rest of the floors are actually express, right? And so the elevators they stop at every fourth floor. And so in those types of buildings, there's a 300% increase in stair use. When they've surveyed people in those buildings, initially people were a little bit shocked that this was being done to their building. But usually by about 6 months later, when they resurvey them, they're actually okay with it, right? And then simple things like just putting points of information, like points of decision prompting, right? So we talk a lot about like educating people. But the evidence is actually pretty strong now that when people are being educated, it may change their intention, but it's usually not that effective in actually helping them be successful at behavior changes. But a way of educating that puts information right at points of decision appears to be actually quite effective at helping people with behavior changes, right? So people are busy in their daily lives, but if there's prompts that remind them of the things that they actually say they want to do during their New Year's resolutions, as an example, that it may help to prompt them to do that. And so things like signage placed at elevator call buttons outside of stairwells can actually increase stair use by a median of 50%. Simple, inexpensive, but of course you got to do it, right? Social support mechanisms, strengthening social networks like buddy activities, walking groups. There's strong evidence that it actually helps to help people increase and maintain their physical activity. The use of community health workers. You know, we've got community health workers, for example, that do TB control, right? And now we've got a different set of diseases, right? So we have community health workers in many health departments that will go out to, you know, watch the patients who are non-compliant swallow a pill every day, so that, or several pills, so that they won't develop antibiotic resistance to tuberculosis. But there's evidence that having community health workers that provide support to cardiovascular and diabetes patients improves their outcomes. So how do we work together to maybe make some of those things happen? Worksite factors, both social factors like incentive systems and also support systems in the worksite, but also physical organizational structures, right? Standing desks, like chairs that are actually cycle machines, treadmill desks. I mean, there's even furniture now for kids that allow them to actually fidget while they're sitting, right? That can actually burn a lot of calories throughout the day. And there are RCTs in these work sites that actually show improved weight outcomes, for example, compared to control work sites. And then school factors as well. Everything from whether children can walk to school and bicycle to school as part of the physical activity that they need, to physical education, So how we locate schools, how we design neighborhoods for neighborhood schools or not really matter. And then even the design of playgrounds, right? There's a whole literature now around playgrounds that can maximize or increase the amount of activity that kids are getting while they're playing compared to other types of designs. As I mentioned, moving furniture and standing desks, meal policies at schools, and then associated outcomes from these studies have shown reduction or maintenance of obesity rates. So maintenance is actually the first step to reduction, right? Because in most cases we see obesity rates rise over time, and individual weights for people are also rising yearly, usually. Improved moderate to vigorous physical activity, and actually also improved academic achievement in students who are more fit. And then the food environment's also really important. So the types of food retail that you have around you will functionally determine probably how good your diet is, right? So if you're surrounded by lots of produce, it's affordable, then you're more likely to eat that. And neighborhoods have low rates of obesity usually when they're high, when healthy food is more readily available at healthy food premises. High densities of unhealthy food premises like fast food restaurants associated with increased weight and poor diets in area residents, both children and adults. There's things you can do, right, within the food settings themselves, like giving point of decision information, what you can do in the foods themselves, like trans fats removals from what's used in the kitchens, gardens, some growing evidence that people exposed to gardening, both adults and children, do tend to eat more fruits and vegetables. And then even, just having access to tap water, right, in our public realm and in our buildings. Some studies, for example, in a controlled trial in Germany that showed that, elementary schools in low-income neighborhoods, the intervention schools that actually ensured that their water fountains were working, they incorporated drinking water into the day, there's some elements of education about that as well introduced, that in those schools, when they're followed over time compared to control schools, obesity rates were better, and obesity rates increased much more in the control schools than they did in the other schools. So if we were to apply the lessons to 21st century crises, what would we do? Well, perhaps we could think about things like, do we need new reportable diseases? I only have one thing in green because one of the things that's regularly done is behavioral risk factor surveillance. So Canadian Community Health Survey, for example, by StatsCan, they do surveys regularly asking about people's behavioral risk factors. And at this point, they have enough sample size, they're able to actually, have estimates at the regional level. But a lot of these other items, like should, for example, diabetes A1C be made reportable? It's been made reportable in New York City, right? And it's being used to create community programming and interventions that would complement, clinical care in the healthcare setting. Environmental health inspections in terms of, what else can we do in the places where our inspectors are already going, like our daycares and our restaurants. Public health, so we talked about that. Policy developments and enforcement that extend beyond healthcare, right? So addressing community, street, and building factors, taking settings-based approaches to working with work sites and schools and daycares. And I'll give some examples of that shortly. So that then requires partnerships with all of these other sectors outside of healthcare, like urban planning, recreation, transportation, development industry, architecture, even human resources, worksite facilities management are really important pieces. And then community engagement, right? So ensuring that the public, too, is engaged in these conversations so that they'll start to say, why is this is not acceptable that my community has, no healthy food in it, I can't walk my kids anywhere, and that there's a change in community resident expectations and citizen expectations of what that our neighborhoods and our buildings and our settings won't just be safe, but they'll be actually more healthy as well. So across different settings, there's things that we can do. I'm just going to move straight into some of the examples that in New York City. So in New York, one of the things that we did was actually create new regulations for standards for food and beverages for children. So prior to these regulations going in, you can basically go into daycares and children are being served all day long sugar-sweetened beverages. Jugs of water were never put out. So a simple thing is just you need to put out jugs of water all day long so that's the primary drink for the kids, right? And then, you know, at meal times you might serve them milk. Limits to TV viewing to 60 minutes or less a day, and it has to be educational programming, and then ensuring that physical activity time of at least 60 minutes every day is incorporated into the programming at these daycares. And then when our public inspectors go in to actually check for infectious disease control and safety issues, they're also checking and monitoring for these issues. So, you know, it's adding a few minutes to that visit. It doesn't cost so much more in terms of infrastructure. School-based surveillance as well. We've been working with schools to actually do annual measurements of children's heights and weights and using that for surveillance. Without that, we wouldn't have known, right, that our childhood obesity trends got reversed. School lunch improvements, everything from introducing salad bars to just provision of drinking water at lunchtime, addressing, you know, issues like no more chocolate milk and sugar-sweetened beverages in the lineup at lunch. This is a bit short, but like, yeah, and then, you know, working with school construction so that when they're renovating or creating new schools, they started to develop, like prior to the work with them, they would always build like a gym and an auditorium. That auditorium would stay like empty for most of the year, except at Christmas time or Easter time. And so now they build a gym and a gymatorium. And so there's functionally two gyms, right? And when they're doing major renos, they'll do that as well. And so working so that their policies become systematized and going forward, they're doing that regularly. You know, for places, and that may happen in Vancouver as well, you know, that are very built up, you may not have extra space. And so we actually created school play streets so that schools that didn't have enough play space, if they had a quiet street adjacent to one of the sides of the school, we were able to work with transportation to permit those streets to be closed on certain days of the week or sometimes every day at certain times so that kids can use that as extra play space at recess, lunchtime, and even for phys ed. Adult settings. I want to emphasize, I think, you know, government, academia, and like healthcare sector work sites should be examples, right, of what we can do. And so, you know, some of the examples of some of the things that we did in New York was we created walking meeting routes in government workplaces, ensuring that stairwell access and those stair prompts are posted, at least in our own facilities. But actually in New York, we created those burn calories, not electricity signs, and then we made 40,000 of them available, and building owners and managers could call and get those signs for free to post in their own buildings. Things like more active furniture, drinking water access, and then policies that would standardize this. So, right, so the next time your hospital, the food contracts are going up to bid, right? Attached to those bids could be new health criteria for what's served. And so when people are bidding, they have to actually show you how they're going to abide by that criteria. Otherwise, they won't make the bid, right? And then, you know, things that potentially could be done now around voluntary menu labeling or involuntary menu labeling, even for existing food premises. Pricing can make a difference as well. So, you know, towards the end of, so in New York, one of the things that we did was the mayor could issue executive orders, right, that impacted how the city does its business. So the mayor issued 2 executive orders during that time, one around food standards for foods that would be served or procured by city agencies. So, and then one was around physical activity and how, you know, all design and construction projects that the city was involved affordable housing, city-related public buildings, so that included libraries, museums, public healthcare sector sites, so the public hospitals, public realm. Most of the streets, parks are constructed by the city, right? And so all those new renovation projects had to use, we created a set of active design guidelines across 12 city agencies. And after we created them, the mayor issued this order, and all city departments now have to use these guidelines. And so, for example, when affordable housing, often affordable housing is built in partnership with either nonprofit partners or for-profit developers. And so the request for proposals, when a city had a parcel of land and wanted to build affordable housing, when it bid that out, it would identify the guidelines that these bidders had to use in order to achieve points on their bid. So the active design guidelines were incorporated right into that, right? And so the systematization, so that over time, more and more and more of our buildings, streets, and neighborhoods, as they're renovated or newly constructed, become healthier, is a really important piece. And then, I mentioned affordable housing. The notion that we could use pilot projects, right? So sometimes, there might be pushback because people are saying, oh, we don't know if this can really work. But, often you can find some early adopters to pilot with, and then, actually undertake research and evaluation of the outcomes in that local context, and then utilize that to scale after that, because, it can help to counter the naysayers. And then on the food side as well, right? Creating, for example, we had this initiative called Fresh to expand supermarket development in food desert neighborhoods. And we worked at economic development and with planning. So one of the things that we found when we interviewed the supermarket operators was they were saying, your supermarket requirements of what constitutes a supermarket is huge, right? And we can't even fit some of that into the inner city neighborhoods, right? So planning had to come in and say, you know what, we're going to redefine a supermarket as a much fuller square footage store. We're going to eliminate the parking requirements that in inner city you don't even need. We're going to, economic development said, a supermarket, if it comes into town, it's going to create jobs in these impoverished neighborhoods too. So we want that to happen. And so they were able to negotiate with the state to say, hey, you know what, if you're creating a supermarket in these fresh zones, you're not going to have to pay taxes on the construction materials, right? Sales tax, for example. And so creating incentives like that. Healthcare settings. So our healthcare settings, right, as demonstration sites. What can we do when we're renovating, even now, in terms of signage for promoting stair use, point of decision signage for like our food place premises, right? The contracts that are going to be coming up for bid when your food vendors change, et cetera. So those are things. And as I said, in New York, we made A1C reportable. And then systematizing, we've already talked about that. Restaurants as well, we introduced trans fat bans, calorie labeling, anyways, we talked about the successes, right? So we managed to actually reverse childhood obesity trends within less than a decade, increase life expectancy, also decreasing, showing significant decline in lack of physical activity and physical inactivity. And then, often, like, if you're talking to other stakeholders, they'll say, well, this is going to be bad for us economically, but actually we also studied, or our transportation department would study things like retail sales around pedestrian plazas and bicycle lanes and new transit lines, and often retail sales would spike, right? Just like, for example, when we tried to introduce non-smoking bylaws before, restaurants were really concerned they would close down, but in fact, study after study started to show that restaurant business actually increased because most people didn't want to be exposed to secondhand smoke. So we're actually starting to see that around the walkability pieces as well. So, I was very fortunate a few years ago, it took a few years, a publisher came to me and said, can you capture this for us for a book for the public? And so there's resources on my website that I've collated from all the work, but some of the stories about how we got this done are also found in the book. And in the latter years that I was in New York, I was also asked to consult on a variety of projects globally. So the book also has case studies and stories from different parts of the world, like Asia, Latin America, Europe. So if it's of interest, encourage your patients to read it too, because, what we need also is for them to feel like outraged that their communities might not have that, their neighborhoods might be less than optimal for the health of their children and their families. Because without that, we won't get the political will that we need, and also the industry demand, right? So developers will respond if people are saying, I don't want to live there, I'm not going to buy or rent there, right? So that's a really important voice. And then right now at U of A, I have a 5-year grant, federal grant, and it's called Housing for Health. We're trying to improve housing and housing developments and the surrounding neighborhoods for health. And we're trying to use the 5 processes that were successful in New York, including partnering across sectors. So we're now at about 100 partners. Pilots. So sometimes you need to have some of those pilots to show that, these evidence-based measures can work too in this local context. We're evaluating health and well-being outcomes in these pilots, but then we're also doing actually community engagement, right? So we're working with community boards and community leagues to actually work to bring their residents to community engagement workshops where residents are brainstorming things that they might want to see that are occurring in other communities, in their own communities as well. And then through the grant, we'll have some budget to help them implement it. And then one piece is also sharing the lessons as we continue. And so as we continue this grant, there may be opportunities for, like for example, we're going to have an annual conference starting probably in fall of this year. And so hopefully if people are interested in this, whether it's you guys or some of your partners in let's say the municipal sphere or et cetera, or your facilities folks, you can send them to the conference as well for more dialogue. And then if you've got great case studies going on, we'd love to receive them and share them at those conferences as well. And I was hoping that at the end I'd have the chance to read an excerpt, but I know we're at 1 o'clock, so if people want to leave, we can end, or if people want me to read an excerpt from an affordable housing case study, we can do it, but I think we might be booted out soon too. So thank you for coming. Anita asked me to. Okay. Thank you very much. Sure. Let's see if anyone has any questions. Yeah, absolutely.
Maybe I could just say a couple words, but I come from a unique perspective. Everybody here knows me as an endocrinologist, but I'm also the BC representative for Physicians for a Smoke-Free Canada.
Yes.
And so I want to make I think everything that you said is great, and I agree 100%. But I want to make the point between preventable versus modifiable. So infectious disease, tobacco, accidents are all preventable. Diabetes, hypertension, lipids are not preventable. They're modifiable. So we can affect the curve, but we cannot completely eliminate morbidity and mortality from those things. So I'm not saying that we shouldn't try to reduce it, but I think it's important that we view it as something different from infectious diseases and tobacco and accidents. Tobacco remains the leading cause of preventable death more than all the other things like accidents, murder, suicide combined. And I think there's this thought that, oh, tobacco is yesterday's thing and we've succeeded, and we have not succeeded.
Well, I think we've had a lot of successes in tobacco. I think we continue to have high-risk populations that we do need to focus on. Doesn't mean there's nothing left to do. There's still lots left to do. I agree with you. But I don't think that we can also not address, I think, some of these other risk factors that now have growing and in many cases strong and sufficient evidence of being able to do more around that we still haven't done enough around.
So I agree they need to be addressed, but I think they just need to be classified separately as modifiable and not preventable.
Well, I would actually ask you to maybe clarify exactly what you mean by that, modifiable versus preventable, because
smoke, they're not going to die of cigarettes.
Yeah.
But somebody, you can't stop eating. You've got to.
No, you can't stop eating, but
you still need salt. You still need sugar. So those things, they're on a continuum. So you can move down the continuum, but you can't completely eliminate. You're not going to get to zero obesity deaths in the world ever, and it's just not possible. While you can, in a utopian world, get to zero tobacco, zero accidents, zero infectious disease.
Okay. All right.
Philosophy.
Okay, thanks. Well, we actually need, I think, folks like yourself who have worked in the tobacco sphere to potentially be advocates for this sphere as well, right? Because your experience in the successes of these other spheres, I think would be really helpful to hear that voice.
Well, I've got to run to
Yeah, thank you. Yeah.
And that's what I get paid for. I don't get paid for my anti-tobacco stuff.
Okay, thanks.
Sorry.
Okay. Yeah.
Does the structure of municipal governments matter much? Like New York City, well, Manhattan, one big city government, whereas, say, Vancouver, the Lower Mainland, is more than a dozen little municipalities that all make their own decisions. Is one better than the other?
I didn't put it there, but well, I think different governments pose different types of challenges and opportunities. So I think you're right. When your health department is part of a city municipal infrastructure, like City of New York, City of Toronto, it does allow for sometimes, like, because you're within the same administration, it's sometimes an easier dialogue. But that doesn't mean it can't be done because in other types of governments, because, for example, in 2011 to 12, CDC actually gave the New York City group that I ran a grant to mentor other communities in the United States on healthy built environment work. And what we found was, like, and they basically said, hey, who wants to sign up? It was really shocking to me, the types of places that did sign up, right? So we had big cities like Chicago, Boston, Miami, but we had the suburban areas like Cook County around Chicago. San Diego actually signed up as a county, so they had both their city and they also had like unincorporated small areas within the county. And San Diego and Philadelphia have also recently reversed their childhood obesity trends, taking this comprehensive environmental approach. We had like a little tribal nation in Oklahoma who signed up, right? And of course the scale of the work is very different. Their work really focused on like using their school as a hub for walkability and for recreation. But it can be done, even at different scales. Different challenges, different opportunities. Yeah, thanks. Alex.
So like Manhattan is kind of a unique situation because of the degree of population density, because it's literally on an island with a very limited real estate footprint, whereas the majority of, Vancouver is a bit of an exception, but most of the other cities in Canada are in these big sprawling areas with room to expand in all directions. So can you comment on the challenges in trying to move some of these interventions to the Canadian system, where the Canadians, again, you got more potential for sprawl, but then you also have the confinement of the climate in which we live in, with a large part of the year being not very pleasant to be outside and walking and all those sort of things.
Yeah. I'll just comment on the climate first. Climate always comes up, regardless of where you go. So when I was working with Miami, they were like, how can people walk and bike here? It's so hot, right? And then, of course, in many Canadian climes, it's like, how can we walk and bike here? It's so cold. Two items related to that, I think. There are interventions that can be done to consider weather, right? I think we haven't done enough of it, frankly. So, for example, when we talk about a bike lane, often it's just like a painted strip on the roadway or off the roadway, right? But if you're in a windy city, could you use landscaping elements to shield some of that wind? In a very rainy city, do you actually need to have maybe some shaded structures over those infrastructures as well, right? As well as over your sidewalk. So I think that there are things that design can play more of a role in. There are cities that have put in place like heating, like warming huts, so warming areas, so that, as people walk around in the winter, they can step into some of these. In New York, we actually utilize things like market spaces, right? So I don't know if folks have been to the High Line in New York, but the High Line is this new outdoor park built on an old elevated rail. And near there, you've got Chelsea Market. Some new markets have opened up, like Gansevoort Market. And so people still walk the High Line in the winter, but then they need a place to go and get warm. So they actually enter these markets, which is actually very good for retail, right? And for boosting retail. And so there's potential opportunities like that, as well as design elements. There's also technological elements, right? So right now it's still very expensive, but there's now technologies that heat the sidewalk, as an example, right? That can make it safer for, like, for example, older populations to walk in the wintertime in winter cities. But it's underutilized. And because it's underutilized, that adds to the cost, right? But if we can pilot and show that it's helpful and effective in decreasing falls, increasing walking, there may be opportunities for more, and then there's also like decreasing of maintenance costs, right? Because you don't have to shovel. I think as more cities consider and developers consider putting these in, it could lower the price over time as the scale increases of purchase. The other piece was around population density. Yes. So yes, it's helpful when you have geographic boundaries that constrain you. And so that is one of the challenges, I think, in places like North America, Australia, that have a lot of land. But those places that have a lot of land, I think it requires us to even be more mindful in the planning, right? So planning around, planning growth of residential as mixed-use residential around upcoming transit nodes, around active transportation nodes. So the planning piece becomes even more important. But it can be done. I know people think of New York, they think of Manhattan, but New York's actually 5 boroughs. So we do have far reaches of Queens, the Bronx, Staten Island, and the initiatives that we've undertaken didn't just stay in Manhattan, right? Like we introduced bus rapid transit to Staten Island. These pedestrian plazas were done across the 5 boroughs. And so it can be done. One more thing to say, but now I'm lost at it right now. But so just to say that it requires potentially more concerted efforts. Oh yeah, this was what I was going to say. I think we often make assumptions about some of the great European cities for walking and cycling, right? Copenhagen, right? On track for having a 50% travel share being bicycles by 2030. Well, when you hear the planners from Copenhagen talk, in the 1970s, they were designed for the car too, right? Like only a single-digit mode share occurred at the time on bicycles. But through concerted efforts at both changing the social and the physical environmental elements, they've managed to change it. So even our assumptions about some of the old world cities are different. And in Copenhagen, you can get from the suburbs to downtown to work faster on a bike than you can in a car, because everything from the materials that they use to how they program the traffic lights, et cetera, to how they maintain those in the winter is more conducive to cycling than it is to driving. So it's not just the central core, but even the suburbs. Yeah. Thank you. Thanks for staying to beyond the bitter end.
Thank you.
Yeah, thanks.
Alex, where are you headed? I'm headed to skincare and
I can take them up to you.
I'm not quite sure what to do.
Awesome.
Should I just leave this here? Or?
Thank you very much.
Thank you.
Anita and
Yes.
Nadia had to go with what they
Yeah.
mouthed to me. Please, please, please thank her. And that was fantastic. And
Thank
it
you.
sounds like the work that you're doing, I mean, I would love if you had someone
Yeah.
just like you here or in our municipality, because the epidemic
Yeah.
needs to be prevented. And when
Yeah.
you show those slides about
Yeah.
infectious control
Yeah.
and stuff, it is something that we can
Yeah.
prevent we make
Yeah.
changes.
Yeah.
Maybe the diseases and the morbidities that have already occurred have occurred, and we
But
change.
even that,
Even
I think
that
in the
we can
disease
change.
management side, I think we need to make it
Chronic
easier. Yeah, the chronic disease
And I
management.
love the mention that you made, like public health workers are going to witness meds, but yet they could take a patient for a walk, or they can walk them to their break.
Right.
Like, there's so much that
Yeah.
can be done if we think that this is,
Yeah.
it needs to be
Yeah.
worked on. I mean,
Yeah.
it just requires thinking outside.
Yeah.
But like, if no one thought outside of those infectious and sanitary,
Exactly.
opening up the street for light, you
Yeah.
know, we would be back in the 1800s.
Absolutely.
So
Absolutely. If we kind of said, oh, this is inevitable. And
Yeah.
at some point we said that, right?
Yeah.
Oh, TB, it's
Yeah.
the poet's disease,
Yeah.
right? Or the artist's disease,
Yeah.
as if it was like, inevitable.
Yeah.
But today, if you get someone gets TB transmitted to them as preventable, people are outraged,
Yeah.
right? Yeah. Yeah, it's on Amazon. It should be in bookstores. I walked over to the Indigo yesterday to see if there's 6 copies there, but it's also on Amazon and there's ebooks as well. Yeah. Yeah.
I eventually want to do a one-day PhD.
Yeah, yeah.
I wonder if maybe I could call you for
Sure.
and that kind of
Sure.
stuff.
See the little like airplane thing? Well, I think I have my contact there. I mean, but there's also a little website here. There's a contact page there as well.
Okay,
So-
I'll get your book and then I might email you something.
Yeah, absolutely.
Yeah.
Is that
That's yours.
Who should do that? Yeah.
Flying back today?
Yes, I'm flying back, so now, I wanted to go to see the Sidney Sherman exhibit at the art gallery.
Yeah.
Have you guys seen it?
I've seen it.
Is it good?
It's interesting. My problem was that directly all the exhibits were all photography ones. Like,
Yes.
that
Right
was the
now,
problem.
you mean?
Yeah.
Yeah.
So it's like, well, if you're going to have one mass photography one, the
Yeah.
other one should be
Sure.
other media. They shouldn't all be
Yeah.
photography, which it was. I thought it was poor planning on their part.
Okay.
Do you want any more?
I'm
in this
gonna,
one?
I'm good, I think.
Okay.
So I'm gonna go see that, and I actually have a meeting at like 3 o'clock, back at West 10th Ave. So this morning I was presenting to like, they have this like public health folks had a meeting. And they're like,
West 10 sounds like Broadway.
Yeah, one
Yeah.
percent is around Broadway.
Yeah.
Across the bridge back.
Yeah.
Unless you take, you could take the Sky, depending on where it was
Yeah.
Broadway. Like if it was near Vancouver General Hospital, then you could take the SkyTrain, right?
Yeah, I think the SkyTrain station, like the Broadway City Hall, is close there.
Yeah,
Okay, then what you do is then from the art gallery, you walk to
Yeah.
the corner of Georgia and Granville,
Yeah,
and you get on there. There's a subway station right
Yeah.
on. There's a street entrance.
yeah.
That one will go.
Okay.
It's like 2 or 3 stops down to the city hall.
Okay. How long do you think it will take?
From the airport?
No, to see the city Sherman, and then I think from there I can
Yeah.
take the.
You can definitely do it in
take
an hour.
The train.
Hour or less.
An hour or less? Okay, so I'm gonna run over, look at it, and then take the
Yeah.
train. Yeah. Okay.
Yeah.
All right. Thank you.
Okay, we'll see you.
Yeah.
I'm
Good to
here
see you.
now.
Glad to.
Yeah.
Bye.
Like I grew up in Winnipeg, right?
Yeah.
So back when I was a kid, they always
Yeah.
had like at major
See you later.
Yeah.
bus stops,
Yeah.
they used to have like heated bus shacks.
Yeah.
You know, from a population density
Yeah.
point of view, like the buses were only coming once every half an hour, right?
Yeah.
So you're not going to be waiting in below 30 weather on the street for
I
half
know.
an hour. So they had these heated bus shacks. It was
Exactly.
great.
Yeah.
But they got rid of them all now.
Right. Right?
So that's really
Yeah.
bad planning.
Yeah.
And it might be that, well, it's too expensive to have the heated bus shacks because we don't have the population density for the
Right.
buses, but then because it's catch-22, right? If
Totally.
we don't have the heated bus shacks, then
Totally.
we're going to wait for the bus.
Totally. And also, like, we often think, whenever we think about, like, biking, walking, or transit infrastructure, people are
Yeah.
like, too expensive.
Yeah.
But then we never hear that when it's like, let's build more highways for the car, right? You know, which then also contributes to sedentariness and, like, chronic diseases, which
Right.
is the most expensive thing in our
Yeah,
in our
that's
country.
right, yeah.
Right?
Yeah. Myself personally, I just live within walking distance of the hospital. So
Yeah.
if you can live within walking
Totally.
distance
You have
of
to make
work,
conscious choices.
yes, exactly. But
That's what I
that's probably
did
the
as well.
healthiest thing, right?
Yeah. I
Because-
walk to work.
Because
too.
walking to work is healthy, but then also avoiding the stress of driving in traffic for 30
Totally.
or 45 minutes.
Totally.
Because that's got to take, even if you never get into a car accident, just that stress has got
Totally.
to take time off of your life, in my opinion.
And that's the thing too, right? Like, if you're gonna take transit too, right?
Yeah.
Like, especially if you're doing it for work or to go to university, whatever. Like, when you have the option of driving,
Yeah.
you know, and you have to adhere to the schedule, then the transit has to be, there's got to be some appeals, right? Like, for example, I'm going to be stuck in traffic.
Exactly.
That's why people take the train. But, well, you can't have a train. You can have bus rapid transit, where you paint a lane and nobody else can go on that, right?
That's right.
Because then it's like, I won't be stuck in traffic, even if I take the bus.
Yeah.
Right? And so that's a good stopgap measure when you're trying to find budgets to expand the layout.
Yeah.
You know?
One of the potential problems of like Canadian cities is that Canadian cities don't pay for shoveling of sidewalks, right? So that's why they in residential areas they put up all these bylaws that you have to shovel in front of your own way, which is always inconsistent. So that kind of detracts from people. Anytime a mode of transportation is not reliable, it's going to be used less, whether that's rapid rail or buses or even walking, right? And so for us, whenever it snows, for example, the SkyTrain shuts down, right? And the buses don't show up. So people will stick to their cars because it's more reliable.
Totally. And then, if you're old, I think you can't even drive anymore.
That's right.
And then you're like, I can't walk. So like the store.
Like when it snows here, you can't use the residential streets with your walker because the streets are not, the sidewalks, let alone the streets, are not shoveled.
I think where we have high numbers of aging populations, we should be considering these heated sidewalks. So in the pilot in Alberta, we're going to be doing that, hopefully. We're working with the developer to try to see if he's willing to put in like heated sidewalks on the development site.
Even like as a pilot project.
And then we'll see what outcomes we get.
Because one of the things that European cities do have going for them over like North American cities is they have more public places to sit and chat and just hang out. Like this concept of the city squares, right? Piazzas, exactly. Because we don't really have that here. To the same, so you don't get the same sort of socialization, casual regular use of it. Like I'm just gonna go sit there and read for half an hour or whatever, right? Or just hang out with my friends and just. So that's one thing that the European cities, the older European cities, have going for them, because that was their main source of entertainment, I guess, back in those days, right?
People watching. You know? I mean.
Whereas with the North American cities, they're more modern, so entertainment was not something that you did in public, so to speak, the way it was in the old days with Europe.
But I still think, you know.
But a lot of it's cultural, right? Like if you build those spaces, people will use them, right?
I mean, you know, I think when you do put those spaces, it's well designed. None of
Exactly.
Depressing and
Exactly.
Like dangerous.
You have to be well designed and well maintained. Right?
Yes, and feel safe. And
like they can't have, like the garbage has to be clean and it has to be safe, right? So there is initial costs and the ongoing cost of maintenance as well.
That's that issue too.
So maintenance costs are always a big issue with these interventions. I'm going to take these up to our offices. Very good talk. Thank you.
Thank you.
You know how to get
We have lots of ideas. Nadia has my contact.
Okay, all right.
Or it's at the back of the book in that little tiny thing.
Okay.
Okay.
Take care.
Thanks a lot.